Hello everyone. My talk today will be about assessment of the LV systolic function using the basic echocardiography. And myself is Dr. Ahmed Farid. I'm an MD cardiology and fellow of European Association of Cardiovascular Imaging. I'm a consultant and lecturer of cardiology at South Canaan University, Egypt. So we'll start by asking why we need to assess the left ventricular systolic function. It's very important to know why we need to assess the left function. And we should say that we need it for the diagnosis and evaluation of heart failure. We need it for the clinical decision based on the systolic function, like a patient with valvular heart disease, like when putting an indication for putting an ICD, and you can see that there are some decisions that based on the ejection fraction or based on the systolic function that can be made if based on your echocardiography finding. And lastly, in patient with coronary artery disease, as it assesses the prognosis and the evaluation of our patients. And in patient with chemotherapy, this is crucial for starting the chemotherapy and for following up and early detection of the chemotherapy-induced cardiotoxicity. So, what are the methods that we have for the assessment of the LV function? We can assess the LV systolic function either by the echocardiography or the cardiac CT or the MAGA or the nuclear scanning, or using the MRI, or using the SPECT, or by ventriculogram by injecting contrast during coronary angiogram. And they all share the same rule, that ejection fraction equals the end diastolic volume minus the end systolic volume over the end diastolic volume multiplied by 100. So this is the same rule for all the methods for assessment of systolic. But we should not rely only on assessing the systolic function by the ejection fraction. Sometimes the ejection fraction may be deceiving. And why the ejection fraction is not so good? Because it is load dependent. So you consider the extreme afterloads and the preloads may affect the ejection fraction. And this is according to the pressure volume load. And also, the ejection fraction is influenced by the heart rate, as increased stroke volume with bradycardia overestimate the true ejection fraction, and in tachycardia, the reduced stroke volume underestimate of the actual function, and in patients with atrial fibrillation represent a special problem not only due to tachycardia, but because LV filling may alter from beat to beat depending on the RR interval. And also, the ejection fraction is best as a marker of the gross LV dysfunction, but may be insufficiently sensitive to identifying the mild degrees of systolic dysfunction, and this is where comes the role for the global longitudinal strain for assessing the mild degrees of systolic dysfunction or the early occurrence of systolic dysfunction. Also, the ejection fraction rely on the level of expertise, and it needs more formal quality control, automation, and the quantification may be desirable for the assessment of ejection fraction by the echocardiography. As we can see here, sometimes geometric dependence, like it's more difficult and may result in some inaccuracies in patients with left bundle branch block and extensive wall motion abnormalities and off-axis imaging. It's load dependent in extreme afterload and as in cases in mitral regurgitation and in high and low heart rate and heart block tachycardia, special atrial fibrillation. This all may affect your results for measuring the ejection. And when ejection fraction is reduced and a pivotal decision such as device implantation or the surgery as in valvular heart disease is to be based on the measurement, more accurate measurements can be obtained using either 3D imaging, echocardiography, contrast, or the magnetic resonance imaging. We also should be stressed that when volumes are required, as in the assessment of valvular diseases, 3D techniques should become mandatory, especially if the left ventricle is disfigured and it's out of the normal geometry. And finally, the follow-up studies should require a 3D strategy or geometric independent techniques such as assessment of the strain. Now we are moving to the basic echocardiography for assessing the LV systolic function. We have either by the 2D, we have by the contrast echocardiography, we have the 3D, and we have the strain assessment. We will start talking by the 2D assessment of the LV function. And we have some advantages for using the 2D echocardiography, as it has no radiation exposure, it's portable and widely available, and it's accurate assessment of regional wall motion abnormalities, especially in experienced eyes. And the image acquisition is not limited by the presence of arrhythmia. You can acquire your images if the patient is tachycardic, bradycardic, in sinus rhythm, or in atrial fibrillation. There is no hindering for that. And the assessment of other cardiac structures, as you can see, also you can assess the valves, not just solely the ejection fraction or the systolic. But there are some disadvantages of the 2D echocardiography, as it has an average test-retest reliability, as if you bring back the patient and do the ejection fraction even in the same setting, you may have some variables in the numbers you are taking. Also, there is a geometric assumptions, and for non-volume related methods, this is one of the big drawbacks or disadvantages of 2D echocardiography. The dependence on variable loading condition, as we have said, the extreme afterload and the preload changes affect the systolic function and the ejection fraction, and also the image quality, as it's operator dependent, and poor endocardial border in 10% up to 40% of the patient may have some loss of the image quality, so this may affect your interpretation to get this LV assessment of systolic function by the cardiography. So how you assess the LV systolic function 2D, we have some parameters for the LV systolic function. You have either the fractional shortening, the ejection fraction, the eyeballing assessment of left ventricular function, and also you have the cardiac output or the cardiac index, the contractility, delta P over delta T, and the T index. And most of these measures that we will mention in this lecture are based on the recommendation of cardiac chamber quantification by the American Society of Echocardiography, published in 2000. The first step for assessing the LV systolic function by echocardiography is for taking good and accurate measurements is proper image optimization, enabling perfect visualization of the cardiac structure, and you could achieve this by proper patient positioning and the proper machine settings like optimizing the frequency, the gain, the tissue harmonics, the sector widths, the grayscale, the focal point, etc. And if you look at these images, in the image on the left side, you can see it's a fuzzy image. You cannot judge on any measurements you are taking from a patient like this. And you can see the generated image mode from this image is fuzzy, and you cannot take your measurements from here. But with just very simple and directed image optimization, the image in the middle, you can see you can take your measurements. And finally, with good image optimization and patient positioning, you can take very accurate measurements like you are seeing on the image on the right side. So let's start by the first thing, the fractional shortening. And the fractional shortening is quickly but roughly evaluates the LV global systolic function, and it's based on the assumption that this correlates with the LV short axis diameter reduction in systole. So the fractional shortening is the left ventricular end-diastolic dimension minus the LV end-systolic dimension over the left ventricular end-diastolic dimension multiplied by 100. So how to measure it? You measure it from the parasternal long axis view, carefully obtained perpendicular to the LV long axis and measured at the level of the mitral valve leaflet tips. And you should be cautious that your plan or the M mode plan is cutting perpendicular to the interventricular septum and perpendicular to the LV long axis. And you can roughly estimate the LV long axis by its imaginary line between the middle of the mitral valve annulus and reaching to the apex of the left ventricle. But it has some limitations. It is only a single dimension, it's representative only in normally shaped ventricles, and also it needs proper alignment. If you just are off axis, you will have a falsely elongated measurements and falsely wrong ejection fraction, and the segmental motion abnormalities or conduction abnormalities affect the accuracy of that method. And how to overcome these errors? Especially the off-axis measurements, you should modify the view either by moving a space above or medial movement to the probe toward the sternum, or using an anatomical M mode if your machine is equipped with this, and if it is difficult to align, use the direct 2D measurements, not the M. So what's the normal values of the fractional shortening? The normal values for fractional shortening is either 25 or 27 in some guidelines, up to 43%. The mildly impaired is from 20 to 24%. Moderately impaired is from 15 to 19%, and severely impaired is below 14%. And in patients with normal size of the left ventricular base but enlarged mid-ventricular and distal portions, like the patient with myocardial infarction, anterior myocardial infarction with aneurysmal apex, the LV volume should be better marker of the LV size rather than the linear dimensions measured at the left ventricular base. So you rely here on the size of the ventricle and the volumes, not on the dimensions only. And do not use the fractional shortening method when the diameter are not representative on the ventricular size, like in patients with regional motion abnormalities or abnormally shaped ventricles. So theoretically, you can also use fractional shortening to derive ejection fraction either with the cube method or the Teichholz formula. These are old measures, but it's not recommended anymore to make the ejection fraction from these measures. And the Teichholz formula gives you slightly better approximation of volumes. And fractional shortening are based on geometric assumption. To some extent, their calculation only work for normal sized ventricles. And if you wish to obtain a rough estimate of ejection fraction from fractional shortening, simply multiply the value of the fractional shortening by 2. Now move on to the most widely used and most indication for ordering an echocardiography is knowing the ejection fraction. So how to assess the ejection fraction? You can use the Biplane disk summation method or the modified Simpson method. The second point is the area length method, the endocardial border enhancement using the contrast echocardiography, the 3D imaging, or the global longitudinal strain. The scope of this lecture, we will talk only about the biplane disk summation method and the area length. So the biplane disk summation or the Simpson method, it's indicated, it's the recommended 2D echocardiography method for assessing the ejection fraction by the American Society of Echocardiography guidelines. So this is the recommended method for assessing the ejection fraction or the LV systolic function by the 2D. Also, it comes with limitation and pitfalls. The main limitation is the apex is frequently foreshortened, and you may have endocardial dropout. As we had seen, you may have a suboptimal echo image quality in 10 up to 40% of your patients, and it's blind to shape distortion not visualized in apical 4-chamber and apical 3-chamber view. And the example of this, if you have an akinetic and aneurysmal part of the basal infralateral wall, you may not see this in the apical 4-chamber or the apical 2-chamber view. You may see it only in the apical 3-chamber view. So this shape distortion may not be visualized in the views that you are using to acquire your ejection fraction estimate. So how to start? It's a direct volume measurements, the Biplane method of discs. It's a modified Simpson method, and it's usually you are tracing the endocardium, and then the machine is dividing your tracing into 20 discs. Each disc is representative of itself, so it calculates its height and its area, and they calculate these areas and put it all together to give you an estimation of the whole volume of the left ventricle. And usually the total left ventricle volume is calculated from the summation of a stack of an elliptical discs. Usually it's number of. So now the machine have the height and the area of each disc is calculated as a fraction of the long LV long axis based on the longer of the two lengths from the 2 and 4. And how to measure this? You're obtaining an optimal apical 4-chamber view with the patient placed in the steep left lateral decubitus position, and you try to see the true apex, and then obtain the optimal apical 2-chamber view with the patient placed in the steep lateral decubitus position with no aortic valve open, preferably with no papillary muscle present. So this is the two views you are taking. But be aware that if you have a normally shaped ventricle, you may only rely on the measurement taken from the apical 4-chamber view only. So how to measure? Then you define the end diastolic and end systolic volume. The end diastolic is the frame following the mitral valve closure, or the frame in which the left ventricle volume is the largest, the biggest LV. You can see this is the end diastolic while the mitral valve is closed. And the end systole is the frame following the aortic valve closure, the AV valve closure, or the frame in which the left ventricle volume is the smallest. And then you trace the endocardial borders excluding the papillary muscles. So you can see here, you start from either the medial or the lateral mitral annulus, and you going up, tracing the myocardium until you reach the apex, and going down on the other wall until you reach the lateral mitral annulus. Then you connect the points between the medial and the lateral annuli by a straight line. And then a long axis is drawn, which is the left ventricular length. It's a point from the midpoint of the straight line that you have drawn between the medial and the lateral mitral annulus and the apex. And to know that you are accurate and there is no foreshortening, the length between this LV length you are measuring between in the apical 4-chamber view and the apical 2-chamber view should not differ more than 10%. So you have some tips here to get the best images. Use the highest possible frequency of the probe that produces adequate penetration. Set your focal length below the mid-left ventricle, preferably below the mitral annulus, and decrease the depth to magnify the LV cavity, and align the transducer over the true apex to ensure the largest chamber diameter. So, step 1, you are zooming and focusing the image on the LV cavity and trying to get the best image you can get from here with all the endocardium visualized and you have the true apex. Then you place the marker on the mitral valve annulus, start tracing the endocardium starting from the medial annulus up to the apex and then to the lateral, over the lateral wall down to the lateral mitral annulus, and then connect between the lateral mitral annulus and the medial mitral annulus by a straight line. Then the LV length by a generated line from the mid of this straight line to the apex of the left ventricle. Again, getting a good apical 4-chamber view, zoom in the left ventricle, trace the LV diastolic endocardial border, then scroll until you reach the end systolic volume, and then you trace the end systolic volume the same way. But you have here some limitations and pitfalls you should avoid while taking these measurements. The apex is frequently foreshortened by the 2D, you have some endocardial dropouts, and you are blind to shape distortion not visualized in apical 4-chamber and apical 2-chamber view as we previously. For avoiding the foreshortening of the apex, you have to define if you are in the true apex or in a false apex. The true apex has two main characteristics that you should know and you should see. The true apex is pinching, while it's a foreshortening apex is moving in and out. And also the true apex is usually the thinnest area of the left ventricle. So if you visualize the apex has the same thickness as the surrounding walls and the appreciable motion in systole, it is likely to be tangential cut through the left ventricle rather than a true on-axis view. And this image has shown us the difference between a foreshortened view on the image on the left side with the green axis going through the true apex. You can see it is thin, and if it is moving, it is just pinching, not moving in and out. But for the foreshortened apex, you can see here it is almost the same thickness or even more thick than the septum and the lateral walls. And you can see here the line is not reaching the true apex by itself. And how to overcome this foreshortening? You put the probe on the outermost, lowermost point of the apex. You trying with your scan and go out and lower until you get a true apex, not a foreshortened apex. And try to use a cutout mattress in your bed of examination to make the patient lying on the dead left lateral position while acquiring the chamber view. And this is how the cutout mattress looks like. Now, moving on to the area length method. This is not frequently used method, but it may have some benefits. The main benefits and the indication: when the apical endocardial definition preclude accurate tracing. If you don't have a very accurate endocardial to trace, you may use the area length method, especially if your ventricle is normally shaped, not grossly disfigured. And here the left ventricle is assumed to be a bullet shaped. So how to measure? You take two measurements. You take the mid-left ventricle cross-sectional area by planimetry in short axis. You take this measurement in the systole and in the diastole, and then the length of the left ventricle are taken from the midpoint of the annulus, between the medial mitral annulus and lateral mitral annulus, and then in the midway of this straight line up to the apex. This is the length of the ventricle, and this length is taken in systole also and in diastole. And these measurements are repeated in endodiastole and end systole as we have defined before how to define the endodiastole and end systolic volumes. So now we are coming to a point, if you have your ejection fraction and you get the number, when to define the impaired left ventricular systolic. We have many guidelines with different cutoff values for diagnosing the impaired systolic function. So in the American Society or in the United States, a left ventricular ejection fraction of 54 would be labeled normal, whereas in the United Kingdom it would be labeled as impaired. And those small differences, the diagnostic labels we give our patient matter. And you just ask someone who is trying to buy life insurance how much difference a label of impaired LV function can make. So, and the latest European Society of Cardiology guidelines of heart failure differentiating between reduced ejection fraction, this is less than 40%, and mid-range left ventricular ejection fraction from 40 to 49%. However, they clearly identified a preserved ejection fraction of being 50 or above. So we have three different cutoff values for what constitute a normal ejection fraction. Is it 50% in the European Society of Cardiology? Is it 52 for females and 54 for males for the American Society of Echocardiography? Or is it 55 in the British Society of Echocardiography? And we can see here, this is the ranges of the ejection fraction of the normal and mildly abnormal and moderately abnormal according to the most recent American Society of Echocardiography. But let's say that, but for those whose left ventricular ejection fraction are somewhat in the low 50s, they are still a gray zone, but any number below than 50% is impaired and any number above 55 is preserved. So the area between the 50% and 55% is a gray zone. You can say it's borderline, you can say it is fair systolic function. You have the choice in this, but less than 50% is impaired and more than 55% preserved. Now moving on to the eyeballing assessment or the direct visual assessment of the left ejection fraction. And when you are experiencing, the eyeballing may be reliable and even better than other 2D derived parameters. And this is especially true for poor image quality because the Simpson method has its limitations here. And as you can see here, you cannot say that the one on the left side is a severely impaired ventricle, while if you look at the right side, you can say this is a normal ventricle without taking any measures, without taking any numbers, just by eyeballing assessment you can judge. And what to look for? You are looking for the inward motion of the endocardium, the thickening of the myocardium, the longitudinal motion of the mitral annulus in the apical four-chamber view, and the geometry of the ventricle itself. And first, look at all segments, especially in patients with regional or motion abnormalities. Some segments might be hypocontractile, while others may have hyperdynamic to compensate for the segment that cannot contribute to ejection. And we see this commonly in patients with acute coronary syndromes or acute myocardial infarction, that the contralateral side are hypercontractile to compensate for the newly akinetic segment. So this where comes the eyeballing assessment in handy, especially in patients with regional motion abnormalities. And when certain segments is not properly visualized, the eye is able to interpolate between the missing data. You are like drawing an imaginary line of the myocardium in your eyes. The eyes don't accept missing points, so it's directed by an imaginary line that give you an idea about the whole function. And here you need intuition, imagination, and experience. So the short axis is interpreting the radial function. However, the radial function is just one aspect of contraction, so you're not just to comment on the ejection fraction by just looking at the short axis. And you should also use the apical views to look for the longitudinal function of the ventricle and observe how much the ventricle shortens in length. This is best appreciated by observing the motion of the mitral annulus. It's better to range it than to sharp bullet it. And here by the eyeballing, you always putting a range, and the range is always around 5% in the ejection fraction. So you say it's 50 to 55, 60, 65, but you don't give a sharp number like 60%, 63%. You don't do it by the visual assessment. You should only classify what you are seeing into it's normal, it's hyperdynamic, it is impaired, or it is severely impaired. As you can looking here, the one on the left side, you can see this is normal ejection fraction. But the one on the right side, this is a hyperdynamic function. So that's the difference you can see without taking any measurements, just by the eyeballing assessment. In summary, the eyeballing is not as easy as it may seem, but yet generally there is a fairly good agreement between observer, and it's never a problem to distinguish between normal and severely reduced function. You only fall in the category if you have it is mild or moderately impaired ejection fraction. Now moving on to other parameters that give you idea about the left ventricular systolic function is the cardiac output, and this is the net result that the ejection fraction result in to send the blood for the circulation is the cardiac output. And how to calculate the cardiac output itself? You can use the Doppler method, and the cardiac output is the volume of blood being pumped by the left ventricle in the time interval of 1 minute. And how to calculate this? By measuring the LVOT diameter in the parasternal long axis view with zoomed image in systole, and the pulsed wave velocity time integral of the LVOT in the apical 5-chamber view. And then using the formula, that stroke volume, it's the pi r square of the LVOT multiplied by the velocity time integral from the LVOT, and then you calculate the cardiac output by multiplying the stroke volume by the heart rate over 1000. Then you have the cardiac output. So the normal stroke volume is above 35 milli per meter square, and the cardiac output is more than 4 milli per minute. And it's common that you should index the stroke volume to the body surface area. So you have the indexed stroke volume more than 35 milli per meter square is considered. Now moving on to one of the other methods is the myocardial performance index, or the MPI. It's also known as the TAI index, and incorporates both systolic and the diastolic time interval in expressing the global systolic and the diastolic ventricular function. So it's not an estimate of just the systolic function, it's estimate about the global function, including the systolic and diastolic function. And the systolic dysfunction prolong the pre-ejection, isovolemic contraction time, or IVCT, and shortening the ejection time, the ET. You can measure this. You have some inputs, you put it in the equation and get numbers. Your inputs is the mitral valve closure to opening time, and the left ventricular ejection time is the left ventricular ejection time, as you can see here from the figure on the right side, what you need to measure. And then you put it in this formula, and then you get numbers. And then it's normal, it's less than 0.45, and more than 0.47 is abnormal. The index has been proposed as a useful method for the evaluation of global LV performance in congestive heart failure, congenital heart disease, and valvular heart disease. On to one indirect method of the LV systolic function, it's the dP over dt, and it represents the time required for the left ventricle for pressure evaluation. You only can assess this if you have significant mitral regurgitation and a good trace of the mitral regurgitation. It's the time interval between belting up from 1 meter per second to 3 meter per second on MR continuous wave trace during the isovolemic contraction before the aortic valve opens. And the formula is delta P over delta T equals 32 over the time measured from belting up from 1 meter per second to 3 meter per second, as you can see here. Yeah, the normal values for this, the normal is over 100 to 1200 millimeter mercury per second. The borderline is from 800 to 1200. The reduced is below 800, and severely reduced is below 600 millimeter mercury per second. And it has some limitation. You should have a good MR signal, as we had said before. It doesn't work in acute MR, as the LV pressure calculation is incorrect at this time. The delta P over delta T is not entirely independent of load, therefore alteration in the preload and afterload affect your measurement. We have also some indirect measures of the LV systolic function, like the mitral annular velocity by TDI, and you can rely on these measurements if your machine don't have the strain imaging and you are trying to assess patients, especially chemotherapy. This comes in handy, the mitral annular velocity by the tissue Doppler index. And here you're putting your pulsed wave tissue Doppler over the lateral and the medial mitral annuli, and you're then taking the average of both and measure the peak velocity of the S wave, as we can see here. This point, you measure this distance, and it's normally more than 8 centimeters per second for the average between the medial and the lateral wall. Below 8, it's considered abnormal. The mitral annular planal systolic excursion, or the MAPSE, also it's a handy tool if you don't have the strain imaging for the assessing patient LV function and following up patients who are in chemotherapy. The M mode over the lateral mitral annulus, As you can see the cursor here, it's over the lateral mitral annulus. It's a surrogate of the longitudinal systolic function. It's normally more than 10, and some references consider it more than 12, but it's impaired if it is below 8 millimeter distance. The endpoint septal separation, it's an old method for assessing the LV systolic function, and it's a distance between the E point of the anterior mitral valve leaflet and interventricular septum on the M mode measurement, and it's normally below 6 millimeter, and with decreased ejection fraction the distance is increased. So the more increase of the endpoint septal separation, the more impaired the LV systolic. So my take-home messages after this, that the assessment of LV systolic function by 2D echocardiography has many methods, and the proper knowledge of acquisition and the limitation of each method is the key to correct interpretation, and more experience plus using many parameters are your reliable results. And thank you.